Okay. So, today I decided to split things up a little bit differently. I had been going through 3 topics in any given week, and today I decided to just go through 2 so that way we could cover a little bit more questions. Yeah, it's just you right now. So we could cover just a few more questions on each topic. And so today we are covering non-systems, and I've got a few questions specifically on wheelchair, and then I've got a few more questions regarding, I've got the next set of questions regarding like neurologic evaluation and interventions. Tonight I've got 16 questions, and it's just covering the non-systems and the neuro stuff. And so, sorry, I just realized that. It's fine. I don't need that. So we will go ahead and just jump right in, and we'll start with question number 1. So a patient with a T10 spinal cord injury requires a manual wheelchair. When measuring seat width, which is the most appropriate method? A, measure hip width and subtract 2 inches. B, measure hip width and add 2 inches. C, measure thigh length and add 2 inches. Or D, measure hip width and add 4 inches. Okay. You guys go ahead and take some time to read over the question again and submit your answer choice. And we'll go ahead and go over the first one. So with wheelchair width, what we're looking for is roughly what we say is like you want to be able to fit a hand on either side of the greater trochanters on both sides. And so when you are measuring a patient for seat width on a custom wheelchair, what you want to do is measure across the widest portion of their hips, right? And then you want to add 2 inches so they have an inch on either side. And so the answer is B. Obviously, if it's too narrow, you have a risk of developing pressure injuries, right? And if it's too wide, then you're going to have a person with poor posture and inefficient wheelchair propulsion. And so just having the 2 inches on either side, so that way you can accommodate for clothing and comfort, and that's going to be optimal. So let's go ahead and move on to number 2. Number 2, a therapist is performing a wheelchair evaluation for an adult with cerebral palsy. What is the correct guideline for the therapist to measure seat depth? A, seat depth should be equal to full thigh length. B, seat depth should be 5 inches shorter than the thigh length. C, seat depth should be equal to the lower leg length. Or D, seat depth should be 2 to 3 inches shorter than thigh length. Go ahead and submit your guys' answer choices, and then we'll go over the answer here just a bit. While you guys are doing that, I'm going to go get myself a drink. What's up, man? All right, so I imagine probably, guess the answer. Oh, probably ready for the answer choices. So the answer is D. So when we're looking at seat depth, you want to go to the buttock to the popliteal fold, and then you want to subtract 2 to 3 inches. So that way you don't have their popliteal fold resting right on the edge of the seat. So again, you don't have any issue with pressure behind the knees, and you're allowing for proper circulation and comfort. If you have too much compression against the bottom of the thigh and the anterior portion, then you can have some venous and arterial compression, which can decrease blood flow down to the lower legs and feet. Number 3, which wheelchair component adjustment most improves propulsion efficiency in a patient with good trunk control? A, moving the rear axle forward, B, lowering the seat height, C, raising the armrests, or D, increasing backrest height? Some of you have already answered. I for sure need this next year. Well, I hope to be here as long as you guys prove that it's helpful. I say you guys prove, as long as I prove that it's helpful for you guys. Give you guys a little bit more time though. I will pass in T minus 37 days. That's right, bruh. Okay, a lot of you guys are going ahead and answering A, and you're absolutely right. So if you think about this, if your rear axle is more posterior, then you have to reach even further back or even lean back to get that range of motion you need to grab onto the hand rim. So if it's more central and you have it more forward, then it's not as hard to get behind that hand rim to be able to push you, right? And so as long as you've got your rear axle a little bit more underneath you, it's going to make it much easier and much more efficient for you to propel yourself in that chair. So that's number 3. Okay, those are the wheelchair specific questions that I've got for today. The rest are going over documentation, PT versus PTA, responsibilities, and different things like that. So let's go ahead and jump into number 4. Which of the following is the best example of an objective statement? A, patient appears to be in pain. B, patient reports difficulty walking. C, patient ambulated 50 feet with contact guard assist using a rolling walker. Or D, patient is improving well. You guys are answering quick tonight, which is good. That's gonna make this kind of go along a little better. You know, last week I think our session was only like 40 minutes long. I'm like, dang, that's gotta be a record. Probably good for like on my end though that I didn't talk as much last time and you guys didn't have to put up with as much just like banter, right? Sounds like you guys got a lot of you guys got the right answer here. The answer is C. So when we're looking at obviously an objective statement, we want to look at objective details. And so a patient appearing to be in pain is not a good objective statement, right? Like if they said, or you were able to detect in some way, like patient reports pain such that range of motion is limited to X number of degrees, right? That's going to be an objective measure. But just saying like patient appears to be in pain, even if they subjectively report like a 6 out of 10 pain or something, that is still a subjective measure of their pain, right? And so reporting difficulty walking, patient is improving well. There's nothing objective about saying they're improving well. Well, what is well? Well for me might look different than well for my 91-year-old grandma, right? And so C is your best bet because you actually have measurable data. You have the number of feet they walked, the level of assistance they needed from a person, and then how much support they needed from an assistive device, right? So like cane versus rolling walker versus 4-wheel walker versus lock string crutches, all that good stuff. I missed last week because I forgot. Well, user, I was done in record time, my friend. So you really missed out because actually you probably didn't. You probably were asleep on time, right? Okay, number 5. Which task is most appropriate to delegate to a PTA? A, initial evaluation. B, discharge summary. C, progression of an established exercise program. Or D, determining a plan of care. Yeah, you guys have gotten quick at answering these, which is good. It means that you're like, maybe you believe in what I say about engaging with material every single week. Active engagement. All right. Let's see. Can a PTA perform mobilizations? I mean, it's within a PTA's scope of practice to do manual therapy, so they can. I don't know if they learn. You know, I haven't ever been over a PTA's education, so I don't know if they learn the like HVLA or grade 5 mobilizations that we do. And so, yeah, it's probably going to come more down, like user says, to the State Practice Act. But if you're just doing like grades 1 through 4 mobilization, I don't think that's going to be any issue at all. But once you get to that point where you're doing like HVLAs, I don't, yeah, okay. Yes, we can, just not grade 5, depending on your state. Yeah, there you go. Perfect. I'm not a PTA, so I don't 100% remember. All right. You guys have got it with this one, right? They can progress an already established plan of care, or they can progress exercises in an already established plan of care, but it's the PT's responsibility to do evaluations, setting and establishing plans of care, and doing discharges, right? So number 6, what is the most effective method for preventing transmission of infection in a clinical setting? I will be shocked if this question is not on your boards, right? This is a absolute chip shot question. So what is the most effective method for preventing transmission of infection in a clinical setting? A, hand hygiene, B, wearing gloves, C, wearing a mask, D, using sterile technique. Good. Good, guys. Good, good, good. Love to see it. Okay, so hand hygiene is the single most effective intervention for infection prevention, okay? Limiting the spread of infection, wash your hands, okay? That is an absolute gimme question on the boards. Number 7, which outcome measure is most appropriate for assessing fall risk in an older adult in a short clinical visit? A, the 6-minute walk test, B, the timed up and go, C, Berg balance scale, or D, functional reach test. Give you guys just a little bit longer to submit answers. Okay. The answer is B. It is a quick, valid, and widely used outcome measure for fall risk screening, right? So your Berg is going to be more comprehensive, but it is going to be longer. The other limitation, and you kind of have to be aware of like which each one is testing. So with functional reach test and Berg balance test, if you're looking at balance with transitional movements, those are going to be the ones that are going to assess more specifically, like task-specific dynamic balance tasks, right? Whereas tug is going to be fall risks more related to gait, right? Because you have gait and a turn and having to walk back and turn and sit, right? And so the functional reach test really isn't a bad one, but the timed up and go is going to be more generalizable to the general older adult population because the cutoff score is the same for everyone, right? Whereas functional reach test is probably going to be more specific to age-related normative values. Berg is a good test to do 100%, but it's going to take you longer, and there's more elements you have to do with the test. The 6-minute walk test obviously is going to take much longer than the tug. It takes 6 minutes. Tug could take anywhere from like 8 to 30 seconds maybe, depending on the level of assistance that your patient needs. The 6-minute walk test, you also need a pretty good length of space to do the test in, right? And so if you don't have like a longer hallway or something like that, then it may not be feasible to do your 6-minute walk test in that kind of clinic. And so answer for that one is B. If you guys have any questions about any of these, again, submit questions in the chat, and most questions always get me, do you have any tips on how to get better at that? That's a good question, dude. Practice. Like Allen Iverson says, we're talking about practice, right? So I would go over though, like if you have good study questions that you have, or like your most questions that you have on your practice exams, I would just go over them, right? Just go over the answer choices and really try to hammer in on, well, why was that a better answer than the one that I picked? Like maybe the one that I picked was a right answer, but not the most right answer. Then really try to look into the rationales and see like, well, why was that one better, right? And if you can justify it yourself before you even look at the rationales, that's even better, right? Because then you're using your own processes of deducting or deducing the answer. But that's probably what I would say is like look up a lot of those most questions, try to answer them. If you're getting them wrong, try to see like, well, what's the reason that that other answer was better, right? So that's probably what I would say. But like generally my response is always going to be like practice more, right? Find those questions that are challenging and practice more. I notice most times in the question they give a hint as to a specific concept or component. Sure, yeah, I mean, I'm sure that's true. Yeah. Number 8, a patient has limited English proficiency. What is the best action by the therapist? A, use a family member as an interpreter. B, speak louder and slower. C, use a qualified medical interpreter. Or D, avoid complex explanations. Okay. Yeah, it looks like most of you are answering the way that I would hope you would. Okay, so your qualified interpreter is going to be the safest and most accurate. It's also the best thing that's going to stand up in court. If you ever ended up getting sued and you were using a family member as an interpreter instead of a qualified medical interpreter, your qualified medical interpreters actually document every bit of what they help you interpret, and so it's going to hold up a lot better in court than if a family member is the interpreter for you, right? Not using a family member also helps prevent like bias. So like let's say a family member is like, oh, I don't really want to say that to them because that might hurt their feelings, or like, oh, I'm going to shield them from this like less than good news, right? And so family members, you're going to have a risk of bias, potentially errors. And another big thing that I have heard in a lot of my individuals who are Spanish speaking is that they don't have as good of a grasp on the medical terminology. That's the same in English too, right? Like if you're not in the medical field, you probably don't have as good of a grasp on the medical terminology in educating patients. And so that's certainly going to be true of like the lay person that speaks Spanish or Portuguese or like Vietnamese. I've had Hmong patients, I've had German patients, and so yeah, like your best bet is going to be your qualified medical interpreters, because that's going to make sure that what you are wanting to say is conveyed accurately the way you want it conveyed, and then they can respond to you in a way that you want to. If you speak more than one language and speak in the language of the patient, do you document that? Yes, Gentry, that's a good or J.O., that's a good question. Joe, I don't know why I said J.O. Yeah, but a lot of times, like, if you are considered proficient in that language, that's something that I would definitely let your employer know about. So if you feel like you are proficient to do evaluations and examinations and treatments all in another language that you are proficient in, like number one, I would tell your employer, like, yes, I am good at that. And so if there's like a standardization that they can put you through to decide, like, oh yeah, that person is qualified to adequately perform evaluations in this language, right? Number two, you should be telling them that because that makes you more marketable. Like here in Northwest Arkansas, we have a large population of Spanish speaking and Marshallese speaking patients. And so if you are multilingual in either of those languages, that you deserve money for that. So use that as a leverage point to get greater pay, right? Because that's going to make it easier for you to be able to connect with your patients and give more quality treatment than someone who can't, right? So, but Joe, that's a good question. Okay, we're going to move into some neuro questions. I've got a few here at the beginning about SCI specifically. A patient with a complete spinal cord injury demonstrates full shoulder abduction, elbow flexion present, wrist extension present, no elbow extension. What is the most likely neurological level? A, C5, B, C6, C, C7, D, C8. Give it just a little bit longer, see if anyone else wants to answer. Your name is Feisty Poots. That's pretty funny. I'm a child. Okay, let's go ahead and go over those. Okay, so the answer is B. So what you have present is you have shoulder abduction, elbow flexion, wrist extension, right? No elbow extension, okay? So that means that you don't have any innervation for C7, okay? If you had, okay, so if we're talking specifically about the Asia, now I did not get super technical with this, so I didn't want to, so just for the sake of ease of question, but technically the way the Asia exam is interpreted is the lowest level of spinal level, right, where you have at least 3 out of 5 with the preceding level having 5 out of 5. Okay, so if we're being technical, if shoulder abduction was 5 out of 5, elbow flexion was 5 out of 5, and even if wrist extension was 3 out of 5, right, because the most previous one to it was 5 out of 5, your motor level, or really likely your neurologic level, is going to be the level of what innervates wrist extension, right? And so if you have no elbow extension, which presumably means 0 out of 5, right? And you definitely can't have a neurologic level of C7 because C7 innervates your triceps, your elbow extensors, right? C6 is going to get your wrist extensors, C5 is going to get your elbow flexion, right? And then C8 is going to be your finger flexors. So because we have all 3 of these present, most likely is incomplete C6 spinal cord injury, right? Number 10, a patient with a T12 complete spinal cord injury is most likely, I said incomplete, it should be complete. All of the questions of SCI on your test should be talking about complete spinal cord injuries because that makes it much more black and white. A patient with a T12 complete spinal cord injury is most likely to achieve which functional outcome? A, independent ambulation without assistive devices. B, household ambulation with CAFOs. C, independent wheelchair mobility. Or D, dependent for transfers. Kamari, there's a lot of you that are popping up as like longtime watchers, and it's telling me to give you shout outs. So let me go all the way back. These are the ones that I know have been longtime users. The longest time user that I know is User, and I can't remember all the numbers after your name. But Gentry, you've also been on here quite a bit. Joe, you have been here on here quite a bit. Vonnie, you have returned. So thank you guys so much. Strawberry Babe 12. Jordan Lewis, a lot of you guys have been very, very consistent with showing up to my lives, and so I really appreciate that. Anything you guys do to help promote me just allows me to be able to make this content, right? It helps support me in making this content. And so thank you guys for always showing up for these lives, because it helps encourage me that what I'm doing is actually helpful, right? And helps me also like gear what I'm going over to what you guys need or want. It also helps shape any feedback you guys give me, helps me shape my teaching in like, oh, that was a terrible question, right? And so I need to make sure that I include or don't include these types of things so that way it's not confusing. Trying to multitask with my license application. Rhea, you've been here. I hope I'm saying your name right. And Rhea, I'm literally going to be your biggest success story. Started from the big sticky notes. Ray. Okay, Ray. No, Ray, you've been here for a long time too. User, first off, number one, you are your own success story, okay? I am just a modality to help encourage your study habits, right? But you guys are the ones putting in the work, okay? So I am just a dude wearing a Bruins jersey and a backwards cap, right? But you guys are the ones that actually put in the work. I just want to be an encourager along the way, okay? So with that being said, take control of these lives such that like if I'm not covering topics that you're like, hey, this is all good and stuff, but I really need to practice doing these kinds of questions or these kinds of scenarios, tell me, because I want to be putting out the stuff that actually is going to be most helpful to you guys. So feel free to send me comments. Feel free to send me direct messages to be like, hey, can we focus more on this next time or in the coming weeks? Because it only matters to me if it's helpful to you. If none of this is helpful to you, then I'm wasting all of our time, right? And I don't want to do that because your guys' time is valuable. Okay, now that I've gotten on my soapbox for a bit, let's go over the answer to this question. The answer is C. So we have a T12 complete, right? And we know that hip flexion is going to be predominantly controlled by L1, right? And so because they lack that L1 innervation, the biggest thing is probably like the next closest. I appreciate you. Sorry, I've been MIA. Had a family emergency. Well, I'm glad you're back, dude. Allison, I'm glad you're back. Can we get out of here by 9:45? Let's see. I'll try, dude. So T12, you're going to have full trunk control. The biggest thing I want to point out here is that even if you have CAFOs, it's going to be a lot of like lurching, like throwing your trunk back to like throw your hip forward. And so it's going to be really energy inefficient. And so even household ambulation with CAFOs is probably not realistic for the complete T12 injury. It's likely that you will practice these things therapeutically in clinic only, but in terms of expecting this to transfer over to home ambulation, I would say is not as likely. So, okay, number 11. A patient with a T4 spinal cord injury presents with severe headache, flushed face, BP 190 over 100. What is the first action you should take as the PT? A, lay the patient supine. B, administer fluids. C, perform range of motion. Or D, sit the patient upright. This is 100% going to be a question on your boards. If you don't have a question like this, again, that's one of those things that would absolutely shock me because this is something that they absolutely want to make sure you guys know. Hey, nice. Ray's already looking ahead to the future. Okay. You guys are absolutely right. So this is autonomic dysreflexia, right? So your first steps always, if you're suspecting autonomic dysreflexia, is get the patient vertical, get them upright. okay? Then you can look up, then you can look for the noxious stimulus, right? If you're checking their Foley, you're making sure that there's no wrinkles in their clothes. You're making sure that your gait belt isn't too tight, that their abdominal binder isn't too tight. You're checking all that stuff, right? Their shoes are loose. Their waistband isn't too tight. 9 times out of 10, in my experience, it has something to do with the catheter. But I have a patient that has episodes of autonomic dysreflexia every time I see them. And a lot of times with that person, it could be like their ankle position, it could be their waistband, or it could just be wrinkles behind their back or underneath their hips. And so, yeah. All right, number 12. A patient presents to PT in inpatient rehab status post 10 days of cerebellar stroke. Which finding is most consistent with a cerebellar stroke? A, spasticity, B, hyperreflexia, C, dysmetria, or D, positive Babinski. And this is 10 days after their stroke. Sorry, that was not super clear. So they had a cerebellar stroke 10 days ago. Some of you are questioning how smart you are. But let's go over the answer and let's talk about why. Okay. So the answer is C, right? So cerebellar lesions are going to lead to your classic symptoms: dysmetria, ataxia, and intention tremors, right? So this is something that all of you should know. But infarcts of the cerebellum are not upper motor neuron lesions, okay? Upper motor neuron lesions happen between the spinal cord and the cerebrum in particular. The cerebellum, none of our upper motor neurons arise or terminate in the cerebellum, and so the cerebellar infarcts are not considered upper motor neuron lesions. And so you will not get upper motor neuron signs and symptoms with cerebellar lesions, okay? So, upper motor neuron signs or symptoms, you're going to have spasticity, hypertonicity, hyperreflexia, positive things like Babinski, Hoffman, all that stuff, right? So if you see these things, don't be tripped up and think like, well, the cerebellum is part of the CNS, not the PNS, and so cerebellum has got to present with upper motor neuron signs and symptoms. It doesn't, okay? Cerebellum is not upper motor neuron presentation. So you guys are right, dysmetria. Don't question yourselves. You know what the cerebellum does, and you know what damage to the cerebellum presents with. So don't question yourselves. Number 13, a patient with multiple sclerosis reports significant fatigue during therapy. What is the best intervention strategy? A, high-intensity interval training. B, schedule sessions in the afternoon. C, avoid exercise. Or D, incorporate rest breaks and energy conservation. I know, dude. There's like 1 or 2 other users here, dude. I was sitting there thinking, but they've got like some profile pictures, and so I was like, oh, I won't get it. Just remember, I'm the OG user. Easy. You always have a badge of my top commenter, so I won't confuse it. Don't worry. Okay. It looks like you guys have all got it. All right. So D, in MS, we have to monitor for fatigue, right? And that's going to be incredibly common in your MS patients. And so you just want to make sure that you're implementing frequent rest breaks as necessary to make sure we don't get worsening of their neurologic symptoms, right? And morning sessions are often going to be better because they are fresher, right? If you wait till the afternoon, then they've got a whole morning that they've already had to do their ADLs and perhaps their work and all sorts of getting up and moving around. And so they may already be fatigued by the time they get to your afternoon sessions. And so if they can work morning sessions in, that's going to be best. Okay, number 14. A patient demonstrates agitated behavior, inconsistent command following, and attempts to remove lines and tubes. Which Ranchos Los Amigos level is most likely? A, level 3, B, level 4, C, level 5, or D, level 6? Chippy, I do these every Sunday at 8 p.m. Central Standard Time. So I have a big list of stuff that I'm going over right now, and I'll show you guys the list soon about, just so you guys know what I'm going to be covering next week. I'm splitting it up a little bit differently. Normally, well, I shouldn't say normally. In the last several weeks, I've tried to cover 3 topics in one night by doing like 5 questions. But one of the things that someone asked me to do is differential diagnoses. And because that covers MSK, neuro, and cardiopulm, I think I'm going to spend all of next week just doing differential diagnoses. Because I think I can pretty easily do 15 questions on differential diagnoses spanning all 3 systems, cardiopulm, neuro, and MSK. So, PTA and NPTE is soon. You're freaking right. Allison, are you still on? If you are, tell me, do you know when the April NPTE is for you guys? Okay. April 8th. Okay, cool. 37 days. I'm getting some weird co-host invite, and I have no idea who that person is. Okay, cool. Okay, the answer is B, right? So your B is going to be your confused, agitated state. Yes, I'm still here. I'm actually taking it in July now. Okay, perfect. I always forget that the PTA and NPTE is usually like, I want to say like 3 weeks sooner than the PT and NPTE is. 4 is confused and inappropriate, I think. So 4 is confused, agitated. 5 is confused, inappropriate. But I like that you're thinking about it. So classic presentation of your level 4s are going to be agitated. They're going to have poor attention span, and they're going to have unsafe and sometimes aggressive behaviors, right? Good lunch. Do you like the Mackenzie approach? I am not a orthopedic PT. I'm actually a neurologic and vestibular PT, and so I don't have to utilize things like Mackenzie a lot. But I will say in my younger patients, well, I shouldn't say younger patients, the very, very basics of what I understand about Mackenzie is that you're doing a directional approach. And so I would say that the directional preference approach has been beneficial to me as a PT when I have to address patients' back pain. But that's not super duper common because I treat more neurologic and vestibular cases. Okay, number 15. A patient at Rancho level 5 is most appropriate for which intervention? A, sensory stimulation only. B, tasks requiring 2 to 3 step instructions. C, independent problem-solving tasks. Or D, structured tasks with simple directions. I do have a friend who lives in Chicago, and he works for a clinic that's like really pushes certification in Mackenzie for like the whole body treatment, and they are dead set that that is like the approach to do in the orthopedic setting. And so I know some people who absolutely love it, and I know PTs who like don't even give it the time of day. So I don't know. I know because I'm a neuro and vestibular PT, I know what I learned in school. I utilize it as a tool if I ever need it, but I don't have to interact with it regularly enough to have a really solid opinion on it either way, to be honest. All right, you guys crushed that one. So level 5 is going to be your confused, inappropriate. They're going to have poor attention spans still, so you don't want to give them multi-step tasks, right, or multi-step directions, because they'll probably get hung up at the first one and then not remember what the next thing is, right? And so these people are going to need structured and simple but consistent tasks, okay? So that way you can just build up that repetition. Can you please explain what's the difference between B and D? Okay, so B, that's a good question. So B, with a person at level 5, they're still confused, right? And so if you're giving them 2 to 3 step instructions in order for them to complete a task, they may not get past step number 1, right? So if I say, I want you to pick up this weight and I want you to walk around, like weave in and out of these cones, and then I want you to place it in the correct bucket based on the color. For someone at level 5, that may be way too complicated for them. I just gave them like a 3 to 4 step instruction. So pick up the weight, weave through the cones, put it in the right bucket based on the color. So someone level 5 probably needs a much simpler instruction than that, right? So it may just be like something simple like take the weight to the right color bucket. And that might be all the instructions I give them. So I'm gonna hand you a weight. I want you to put it in the bucket I want you to put it in the bucket of the same color. Something simple like that, right? Yeah, they might swing on you. I know, dude, the more instructions you give them, the more agitated they likely become because they're just like getting confused and they're like, I don't know. I've had patients that are just like, do you think I'm stupid? And I'm like, no, I'm just trying to tell you what to do. So, but anyway, okay, so last question. We are just about, it's almost 8:45. Of course, Ashley. Ashley, you were also a long-time watcher. I appreciate you being on here. Maddie, I know that you have popped in from time to time. I hope that this is something that you find beneficial, or if you think that your classmates would find beneficial, feel free to point them in my direction. I'm going to be doing this up at least until you guys take your boards in July. So. All right, number 16. A patient post-stroke presents with increasing spasticity in the elbow flexors. Which positioning strategy is best? A, elbow extension with forearm supinated. B, arm tucked into body. C, elbow flexion with pillow support. Or D, shoulder internal rotation. I'm trying. Oh my gosh! I didn't know how many people in your class, Maddie, qualified for the April exam, but that's awesome. You might be the first person I know that's taking boards early if you can. That's sick, dude. Okay, so you know this. I had Hannah in clinic, and she was telling me where you're from, but I can't remember anymore. But I know that you have been out in Nashville. Are you from Nashville originally? Are you planning on like working in Nashville when you get out of school? While Maddie and I have this conversation, let me go ahead and give you guys the answer. You're absolutely right, guys. It is A. So I'm kind of back and forth about how I worded this. So to inhibit flexor center tendencies, you're not going to inhibit flexor synergy, right? See you later, user. Reno, Nevada. I knew it was somewhere out west. Gonna work at Vanderbilt, IPR in Nashville after graduation. Oh, dude, didn't you just have a clinical out there? You got a job offer. That's so sick. Have to head out and round up the dogs. All right, Courtney, you have a good one, dude. So you're not really gonna inhibit or prevent tone itself. We really just work at managing tone to try to promote function despite the tone, right? And so you're not going to necessarily inhibit the flexor synergy, but you can inhibit its tendencies to put people here, right? And so you want to position them in the opposite positions that their synergy pattern wants to put them in. And in this case, you want to put them into extension and supine, because a lot of times these patients that have flexor synergies, they're going to be internally rotated, flexed at the elbow, flexed at the wrist, and pronated like this, right? And so you want to get their elbow extended and their forearm supinated, so that way you prevent the development of those contractures, okay? Avoid reinforcing those flexor patterns. That's why C is a bad answer, because if you just let them with pillow support sit in elbow flexion, then you're also putting them into shoulder internal rotation, and you're just going to help reinforce those synergy patterns, which we don't want, because we don't want these people getting contractures. All right, that is all my questions for this week. Thank you guys for hanging in there with me. If you have any questions about something that you want to go over, that you want me to include, I'm more than happy to do that. Next week, we're going to go over more differential diagnosis, and I will go through MSK, cardiopulm, and neuro differential diagnoses. In the coming weeks, though, if there's stuff you guys want, don't be afraid to message me, direct message me, and I'd be happy to add it to my list of stuff that I'm going to cover in the next few weeks. Thank you guys. You guys tell me thank you a lot, but it's really, you guys are the ones that sit on this when I sit here and just jabber. And so thank you guys for showing up. Wait, this was so cool. My first time seeing this. Do you do this every Sunday? Yes, Jorge, I do this every Sunday at 8 p.m. Central Standard Time. Next week, we're going to go over differential diagnoses, and I will probably also show you guys next week what will come up in the next few weeks between now and boards in April. And so you guys have a good night, and if you guys have any questions throughout the week, don't hesitate to direct message me. I'm happy to confer with you guys throughout the week. But all right, you guys have a good night. I'll report back to the class that these are helpful. Okay, thanks, Maddie.